And good morning, everyone, and welcome back to the Care Management Training Initiative. My name is Ruth Colon-Wagner, and I'm the Director of Training and Development with the New York Association of Psychiatric Rehabilitation Services. It is our third webinar in the series, and it's Navigating Complex Systems. And before I introduce you to our presenter today, I'd like to remind you of some upcoming dates. First, the second face-to-face session for supervisors was held back in July, and due to most people being on vacation, the high vacation season, we're providing everyone who missed it in July with an opportunity to join our makeup session, and that's going to be held on September 14th. It's going to be a very interactive session, and we received amazing feedback from everyone who attended back in July. Please review your email for information on the 9/14 makeup date. And our partners at the Coalition of Behavioral Health Agencies have sent an email with all of the information. So we also ask you to RSVP, and you can do that with Laura or Margie from the Coalition. A reminder, Learning Collaborative, the dates. The Learning Collaborative for Supervisors specific to the topic we're discussing today is coming up. The All Supervisors Call is scheduled for September 20th, and Paul Margulies of CMTI will facilitate, and today's presenter, Peter, will also return. And then following is the upcoming regional supervisor calls, and those are regional. And Region 4 is scheduled for October 4th, Region 5 for October 5th, and Region 6 for October 7th. And again, please keep an eye out on your emails for those and more information on specific dates and times. We also know that many people watch these webinars as a team, so we ask you to please take a moment after the webinar to send the names of everyone who's in attendance. And immediately following the webinar, you're going to see a post-event survey window appear, and this is where you will need to document all the names. And so, Amanda, I said you added Vicki, so please just stick around to the end and make sure that her information is entered there. But thank you so much for being ahead of everybody. So if you have any questions throughout the presentation, we ask that you enter them using the on-screen question box on the lower right-hand side. We're going to make certain really to answer all of your questions, and this is going to go out to everyone in participation today via email. On to today's webinar, I'd like to introduce you to Peter Bauman. He is our facilitator for today, and he is Director of DSRIP Operations with the Finger Lakes PPS. He has 15 years of social work experience, 9 years of managed care experience, and 7 years of reporting experience. So that's it. And we're very happy to have Peter join us today. Thanks so much. Peter?
Thanks. I appreciate everyone's time today, and I know we're coming off a holiday, and I took all 4 of my kids to school today, so talk about navigating complex systems. Certainly that comes into play when you're trying to look at taking kids to 4 different schools today. So welcome, everybody. I know time is valuable for all of you, and I hope you all had a nice holiday weekend. So kind of begin our time together. I think it's a great topic that we're hitting on today. There's a lot going on in the healthcare world, and I think one of the things that we're trying to do here is talk about on a high level how we can meet some of those needs. I know that there's an hour and change is a lot to listen to, but we'll do my best to keep you guys interested and involved in the presentation, and hopefully the slides will sort of do to ask some questions because there's quite a bit going on.
Yeah.
Go ahead.
Ruth, I'm so sorry to interrupt. Someone just informed me that our face-to-face training makeup date is not the date that I gave you, but it is in fact September 13th. Sorry about that. The makeup face-to-face is September 13th. Laura, for reminding me. Okay.
Oh, that's fine, Ruth. And if you see any questions coming by on the screen or somebody sends you an email with questions, I think it would be good to entertain those throughout the presentation because, again, I do think it's a long time to hear one voice, so don't apologize for interrupting and hop right in. So.
All right, thank you. Will do.
Yep. Okay, back to the objectives of today, and I think they sort of tie together and are intertwined and interchangeable, how these are all connecting. So the first thing we're going to do is start to look at the changing landscape in the healthcare delivery. Things are changing very rapidly. There's a lot going on, particularly in New York State, but also in the advent of the Affordable Care Act. There is a ton of information, a ton of processes that are being looked at, so I'll touch on a few of those. And that'll lead into the discussion about some of the New York State initiatives that are going on currently, certainly around Medicaid redesign. And Jason Helgerson and his folks are really reshaping how Medicaid is delivered in New York State, which I'm sure I don't need to let you guys know, but he's a pretty passionate guy and has come a long way, I think, in a shorter period of time. Then we're going to touch upon how to collaborate with managed care providers, and the reason why that's becoming more and more important in our work is that all of the services that typically used to be carved out and fee-for-service type of activities, which we'll talk a little bit about today, we're going to have to figure out as providers really to work with managed care companies in a way that's meaningful and in the best interest of the people that we serve. Managed care is being invited to the table to a lot of these discussions and how services are delivered. What we'll talk about is the relationship with the primary care physician and the healthcare providers. I just wanted to take some time out. It's just a little bit of time to really talk about how we can interface with medical providers because that's so important to the initiative of health homes. And really, you are a key player, and this is not my opinion, it's the opinion of New York State, that health home case management services are pivotal to the delivery of health care. And we'll talk a little bit about how you can interface with those objectives. Before we begin, what I always like to start out with, and for those who are new to this presentation, what I like to always remind ourselves is about the individual. So I think we have a ton of information coming across our desk. We have assessments to complete, metrics to complete, paperwork, home visits. All this information needs to be tracked and monitored, but in the end, it's a relationship that you have with the individual. All changes, all these wonderful services are great and are available to individuals in a lot of different settings. But it is up to the individual to navigate through the system. Again, is key. And in the end, the individual drives the change, and you figure out a way to support that change. It's to understand the individual's perception of the problem. We think that when we go into a situation, when we're doing that initial assessment, or the individuals that we work with, we may think that their lives are a mess, quote unquote mess, that they really need some help, that they need to, if they just had these 2 or 3 services, then we would be good to go. But I always am reminded that it really is how the individual understands the perception of their situation that matters, and the goals follow. So I guess that's one thing that I always remind myself when I'm trying to work with individuals and providers, that what I may think is a real issue or a real problem really might not really be an issue for that individual. So we have to meet them where they're at. We have to put connections between what they perceive, what the quote-unquote perceived issues are, and work on collaboration. So that's one thing that I certainly didn't want to understate. What I want to talk about, and again, when it relates back to the other slide, is readiness for change. And I think it's important to always go back to some of the literature that is out there. I did leave a link in there, but I guess my point is that there is a ton of tools and a wealth of literature on readiness for change, because no matter what tools I or anyone else gives you, you have to really know where the individual is at. And I would encourage you to do your best. I know some of these trainings that are offered here through this forum really look at the motivation to change and really get at some of the issues going on with individuals and how that impacts their readiness. I encourage all of you to sort of get the information that's out there. Okay. So the next, I want to talk a little bit about sort of getting into our first objective is looking at the healthcare delivery system and how we interface not only with insurance companies but also providers, and really how things are changing in the market. The market is driving this change, and I think that we need to be cognizant of the choices that are out there for individuals. Maybe I should retitle this slide, because I think my point that I wanted to call out in this particular slide is consumer choice rules the day. I always make the analogy of is Amazon. So why does Amazon succeed, right? So Amazon gives you choices. It's the access. There's reviews that occur on Amazon. There's point and click. There's ease. The insurance market is way behind, but slowly moving towards that model. And the reason why that's important is because it isn't that someone's going to be in Medicaid all their lives, changes all their lives. I'm sure some of you have changed insurance providers over and over again, depending on which job you're in. And we're fortunate to hopefully have options for insurance. The point is that individuals are going to move in and out of products, in and out of provider relationships, and consumer choice is going to rule the day. And the Affordable Care Act and definitely some of the Medicaid redesign initiatives are doing is they're paying for this ease of access. They're paying for the quality of care. They're going to be report cards for providers. People monitoring performance, and what's going to happen is that the individuals receiving the care with providers are going to have access to that information. And I would encourage all of you to start to look at some of the information that is on the managed care websites or even the hospital websites. The scoring that is involved. There's rating of providers. You can get all of that information online. It's quite a bit of information, but really it's working with the individuals about the choice that they have in the delivery of their health care. And that changes what the providers start to look for. Okay, some initiatives that are out there currently that are impacting the system delivery. I'm sure that some of you know most of these, but some of them is driven by the Affordable Care Act. patient-centered medical homes. NCQA is a national body that looks at quality of insurance companies and providers. Part of what NCQA looks at, they look at quite a bit. The National Council for Quality Assurance, they look at things called HEDIS measures. HEDIS measures really are ratings of providers, and it looks at all sorts of metrics related to a provider's performance. ACOs, accountable care organizations. These providers for accountable care organizations, what they're doing is they begin to share the risk for the care of the patient as opposed to the insurance company. How does that impact you? Well, I think the key thing that we're talking about is value over volume. And as you'll see through all of these, as we go through the slide deck, we'll remember that key phrase, that it really is value over volume and moving towards value-based care. And we'll talk what value-based care means. New York State is doing, which is quite a bit, in certainly the Medicaid space and other spaces as well. It's sort of trickling down. But I think what we're doing in regards to Medicaid and the initiatives that are happening, things that I wanted to touch upon. And I think, why are we redesigning this system? Why does it make sense that, why does New York State even care about this stuff? Well, what the data suggested a little bit about on this slide is we're looking at high cost, low quality. So what was happening is New York State was a lot of money per recipient, and I don't know if folks can see this on the slide, so I'll call it out a little bit. But the cost per recipient starting in 2003, again, think about this. This is per recipient. Was about $8,500 per Medicaid recipient. And it started to trend upwards. And so it peaked at about $9,600, $9,574 per individual. And with that money going towards the recipients, still having low quality. It made everybody sort of pause and say, if we're paying all this money, should we be getting the biggest bang for our buck? And so what happened is that the person was charged with sort of looking at this and the Department of Health to figure out the best way to move Medicaid forward. And obviously it called out sort of an issue if we're spending all those dollars with very little quality. So that's kind of where New York State sort of began to really start to look at all the initiatives and what was happening in healthcare. Redesign, a few things came to the surface. So NRT is a pretty complex system and initiatives, and you can sort of spend almost a day, maybe even more than a day, on a lot of these initiatives and how they came about. And also, one of the things that we also know about Medicaid redesign is that nonprofits have to be ready to change because it's a moving target. I think the aim is always better quality care, but these initiatives based on the time, based on what you're supposed to do, they change quite a bit. And so, not for the faint of heart, I guess, is what I would say. So let's start to look at some of these initiatives. There's health homes, obviously. You guys know about that. There's HARP. There's DSRIP that I certainly have learned more about in the year and a half that I've been involved with PPS, and we'll talk about that a little bit. And then there's value-based payment versus volume. So let's start with HARP and begin the discussion about HARP is key to existence and who is eligible. So when, what they're trying to do is they're trying to target a certain population. That population, and again, this is very high level. There's obviously quite a bit of rules around HARP about who's eligible. Really targeting individuals with substance abuse disorder, behavioral health disorders. Interventions around HARP really begin to get at community integration. The thing is that if you address and help people integrate in the community, you also look at addressing the social determinants of health. So that's a key point. So tying, and you'll see this over and over again, social determinants of health, how an individual does in their overall well-being. So that could be anything from transportation to food pantries to shelter to getting school supplies for their children, getting access to community supports. It's really going to help the individual get to where they need to be. And the theory is that if you address those things, you're going to improve the quality of life for those individuals. The other HARP is typically these services were for a select few, usually under the OPWDD population, but now we're widening the scope of services. Will individuals have available to them through HARP? Okay. And again, if you work in the OPWDD field, none of this should be new to you. So these will be services that will now be paid for by the MCO. And so the MCO is going to be quote unquote managing these visits. But I know that there is certain grace periods where really initially it's going to be similar to other rollouts across the state in regards to how much the managed care company can be involved. But look at all these services. So there's rehabilitative services, non-medical transportation, family support, educational services. So it really assumes multiple interventions are going to be needed for complex patients. To these services here that people are going to be accessing, okay? And again, it's all about whether or not the individual wants these services. It's great to have them, but how can we engage them and get them plugging them into these services when they're ready? Why does this matter to health home care managers when we even care? Well, a reasons. One is health home care managers will administer the face-to-face assessments. You know, health home CMs are really going to determine eligibility for HARP and expanded services. So health homes, again, are key for individuals, the connection for individuals to these services. And the NRA is out there. This is an assessment that the state has chosen, has a lot of information on it. From that assessment, you guide the individual to what they need. Also, this assessment is billable as a health home service. HARP members will be offered. Obviously, they're eligible for health homes, but they decline just like any other service. They can decline whether or not they want that service. You know, health home case managers are going to be integral to the success for the state because you're going to be, once again, called upon to be on the front lines to meet the needs of this population. So one image that I like to think about when I think of health home case managers, and I think the state really has called out that service in almost all the initiatives. And when I think about that, you know, the health home manager really is the conductor that helps the person negotiate the services between all of these providers. Coordination, the amount of you know, moving parts. The role of the health home care manager is to navigate between these services to get the individual the right service at the right time. And a skill and a lot of knowledge to know really what's out there. So that's an important piece. And as you'll see, certainly with DSRIP and the primary care initiatives that are out there, home has a tremendous amount of visibility and is called upon to really help implement what the state is asking providers to do. Opportunities for health homes. Well, again, as I said, it provides expanded services to individuals, makes things more makes folks eligible for certain things that they might not have been eligible previously. You're going to, again, see partnership with the MCOs, the managed care companies, and with DSRIP. And hopefully you're seeing the theme here. MCOs, DSRIP, care management for all. They're all connected, okay? So everything aligns with one another. So one of the things that the state called out was saying that HARP provides new resources for the achievement of DSRIP goals. So let's see those DSRIP goals. What is DSRIP? So DSRIP is an initiative, okay, that incentivizes community-based providers to work together. So that's an important distinction with DSRIP. DSRIP is not capacity building, not a new service. It calls for really providers in a region to come up with the best ways to meet the goals for that region and collaborate together. And what I have to tell people when it comes to DSRIP, because a lot of people ask me what it is, and it's hard to pin it down. And the reason why it's hard to pin it down is that it is a regional focus. There's a lot going on in particular regions. So, for instance, in our region, I work for the Finger Lakes PPS. Certain initiatives that are going on that are unique to our 13-county region. Whereas if you go up to the Adirondacks and the Adirondack Health PPS, they're doing all sorts of things with the DSRIP funds that are different from Finger Lakes. But the key things related to DSRIP are collaboration, using the support of IT to help that collaboration, and care management. So some big key foundations for DSRIP. Reiterate that again. So it's health care management, IT, primary care. Those folks work together to collaborate and implement a system that works in the best interest so we're not going over each other and duplicating services. The goal of DSRIP, well, it's simple. is to reduce avoidable hospital use by 25% over 5 years. With great goal, and there's a lot of ways to get there. A lot of it is outreach, a lot of it is prevention, sort of collaborative efforts that are going on. And so how do we get at reducing avoidable hospital use? Providing principles that the state has laid out. Patient-centered, so that's the number one thing. How are we taking care of the patient? It has to be transparent. It has to be collaborative, accountable, and value-driven. Again, great goals, but how do we get to it? So what I would suggest is what New York State did is they divided, and I'm going to leave the presentation for a little bit and show you guys the website. So bear with me here. What I want to show you folks, how the state looked at DSRIP. Hope folks can see that on the screen. Ruth, can folks see that on the screen?
Yes.
Great, okay. So I think it's important, whatever county you're sitting in, that you start to look at this page, okay? Because the second thing that I put down, or I think it might have been the fourth bullet that the state wanted, is transparency. So you go to any county, okay, Hamilton County, anything on a particular PPS. So a PPS stands for Performing Provider System. So again, the state really wanted it to be transparent of what's going on. If you're really bored, which I don't think you guys have the time to do this, you could find out how Adirondack Health and my PBS or any PPS in the state allocated dollars. You can find out to the dollar how information sharing is beginning. Each one of them has a website. In the website, you will find all the information that they're doing, okay? They'll talk about DSRIP, they'll talk about the initiatives that are going on, they'll talk about the projects, okay? So I'd encourage you, again, to go to these particular, see what Delaware County has. We have multiple providers. The reason this with you, and it's important, is that in every project, it's a call for them to be a part of the project. You will find in each PPS there's going to be multiple projects related to Homes interface. And I can't understate how that's important. So why are the PPSs important? The PPSs, what they did is, which was a pretty interesting task, is they had to go into a community needs assessment. And all these documents are online. Community needs assessment look at and related to poverty, information related to the amount of providers in a particular area, information related to the IT resources, information related to the hospital systems, and on and on and on. Why is that important as a health home care manager? Well, I think depending on which county you sit, it'll be important to actually pull up that community needs assessment, because I think it really targets, or actually has a pretty good summary of the needs that are in your community, but it also identifies resources. So I would encourage all of you to take a look at that. Why is that important? Well, from that community needs assessments, the PPS has selected projects. And those projects really look at a couple of key things related to health homes. Okay? So what sort of health homes come in? So if I have all that information, it's great. What the heck does it have to do with us? Well, what I did is I took slides from a state presentation that Greg Allen did. So again, these are the state language coming from this presentation. And what he and the Department of Health expects for health homes is obviously those individuals, think of the primary goal to reduce hospitalization by 25%. The majority of those individuals on Medicaid would be eligible for a health home. And what we need to really look at is transforming the system for health home involvement. Okay, health home is not the end all, but a key part to providing a service that's going to impact the delivery system. So it's looking at care management for high-risk populations, meeting with hospitals about the discharge process. One of the things that I would encourage, and I think that this is happening organically, health administrators, health home supervisors, health home managers, at a minimum, should be at least having a seat at the table with the PPS, or at least having an interface with the performing provider system. Because again, all of the projects, especially 2AI, which is a project name, calling for an integrated delivery system that encourages the health homes to be at the table. I want to pause here and just give a couple of suggestions. And again, I think this is happening already, so I apologize for folks that are already highly involved with PPSs. But what I found, certainly in some of the rural areas and actually some of the urban areas as well, but rural in particular, is that nobody knows what a health home is. No idea. When I go out to the hospitals, when I speak to the emergency rooms, folks do not understand what a health home is and how they can be useful to them. So I think a good first step for any health home is to look at, do you have relationships with your hospitals? Do hospitals know about your referral process? How often do you meet with hospital teams? Again, do you have a connection to the ER, emergency room in your community, and do you know the social work team? And again, it's going to depend on urban versus rural. I think, in one of the urban settings, there might be embedded health home care managers in hospitals. But in some of the smaller settings, I've found just starting the conversation about what a health home can do for individuals and being creative about how we can help your emergency room team be quite a good discussion for you to start having with providers. Okay. So I would encourage you to think about some of those topics and start reaching out and really have an ongoing conversation with healthcare providers in your community, specifically hospitals, about how you can help them with DSRIP payments. Okay, and it really is getting your name out there. Okay. All right. Let's look at value-based payment. I have to admit that I don't know all the ins and outs of value-based payment, but I wanted to give you a high-level, at least a high-level overview about what that means and how you can impact. Put simple value-based payment. Quantity versus quantity, okay? So think of the old, you hear terms like fee-for-service. What does fee-for-service mean? I apologize for folks that have know this mantra. Fee-for-service is you get a service, you pay for the service. With fee-for-service, that what it does is it incents providers to provide more services. So you're not targeting individuals looking at their overall care, you're more worried about getting folks in the door. So you want to incent volume, what you want to incent is quality. So what value-based care really begins to do is to incent providers to begin to look at all the individuals that they're serving and try to provide them the right care. So when I mentioned HEDIS and QARR, I mean, you don't need to know the definitions of these things, but essentially what HEDIS and QARR look at is how is the provider doing? Are individuals under their care getting the services that they need? So it's to know at least these terms because all of your physicians, including the ones that you go to, and that the individuals that we serve go to, are responsible for these metrics. And a lot of them deal with prevention, follow-up after discharge, access to a PCP, wounded screenings. Really, that's when you think of HEDIS and QARR, that's really what it gets down to. So what QARR is essentially the New York State guidelines for managed care companies to make sure that their Medicaid members are getting the care that they need. So that's what QARR stands for. So it doesn't matter to us. Okay, this is something that I think about in regard to case management duties and health home. What it really looks at is prevention guidelines, access to providers, not just medical providers. It could be cardiologists, behavioral health specialists, and for those folks in the behavioral health world, they really do have quality indicators that the state is looking at in regards to access and getting the care that they need. What's happening after discharge, medication compliance, and chronic condition. Are folks getting, so for instance, what I mean by chronic condition and best practices, the best example that I can give is that if you have a diabetic, there are certain screenings and certain things that really an individual needs to do if they are diabetic. It could be getting blood work for an A1C, checking, having an eye test, going to a podiatrist. So there's all sorts of things that a diabetic needs to do. What is happening is as a provider, as a primary care provider, judging whether or not that diabetic got all those services based on guidelines, and incentivizing providers to follow up with individuals to get that testing will lead to payment. Okay, so again, getting away from getting a service to managing the quality of the intervention for patients that you serve. Okay. What's the matter? Why do all these quality metrics, why all these things that are happening in healthcare? And I always go back to the slide about being the conductor. And this is the best way that I can see it. So you have the individual and what home care manager look at all, think of the individuals that you serve. Certainly the higher risk individuals, people are involved with their life, right? Just on a provider level, forget family, church, community. I should probably add this to the slide. They're dealing with a lot of players, MCOs, the PCPs, the specialists. And I think the value of a health home care manager is to be that conductor. Use the metaphor that you want to use, the quarterback. Really trying to figure out the best way to see the bigger picture for the individual. I mean, I know of some circumstances where I worked in a managed care arena and actually in the mental health field. If someone got admitted to a medical admission or even a behavioral health admission, there's a real concern out in the field, and I'm sure that a lot of you share it, that potentially you can have 6 or 7 people calling one individual. You can have the PCP calling them because they have a case manager. You can have the health home yourself calling, the MCOs calling, the specialist might be calling, maybe a behavioral health provider calling. So how can the health home assist with that is, I think one of the things is knowing who's involved and trying to put forth a plan that if an individual gets admitted to the hospital, who's going to outreach? What's going to happen? I know what would happen if I had 7 people calling me. I would hang up the phone and wouldn't answer. So I think that you know, we're all concerned about individuals that are a high risk, and where the health home care manager could be that buffer to tell people that, you know, follow up on this discharge plan, you don't need to call this individual, or maybe you have one particular individual following this person. It could be you, or maybe a case manager in the PCP office working with an individual. So that's, I think, a pretty darn important role for a health home care manager. Okay. I guess the one thing that I would say in regards to some of these quality metrics that we're talking about is that you need to understand that the goals align with your goals of getting the individual the right service at the right time aligns with everybody else on this page. It's an important part that you have a stake in the game to help all of these individuals achieve their outcomes. That is a huge advantage for the health homes. Okay. So let's another complex system, the MCOs, the care companies. So, mind when you think of the phrase managed care or health insurance company, you know, there's a lot of press out there. They're not well liked, a lot of them. Sometimes it depends on what area of the state you're in and how managed care is perceived. Okay, a lot of people have this version. I know this is kind of fuzzy here, but a lot of people see it as, you know, so you have a patient, and the patient is asking, or the individual is asking, wrong doc, and came in for a visit. And the doctor's saying, well, I think there's something going on. So the insurance company is in the middle there of the care. So I think historically, that's the perception. There was a huge shift in managed care. I don't think it's happened over the last 10 years. I think it happened about 20 years ago, where really the managed care companies were told to back off and sort of pay claims and sort of manage the risk. Now, managed care companies, certainly with the advent of Affordable Care Act and some of the New York State Medicare initiatives, the landscape has really changed. Managed care companies are held to a pretty high standard, which is not a bad thing, for care that they are providing oversight for. So managed care companies have to worry about all of this that I've identified here. it's access, it's quality, okay? It's cost is a part of it, but I think what's happening is that with the intervention, right along or however you feel about it, the government is really looking at, in order to set pricing or payments for a managed care company, you have to demonstrate that these access and quality is available to the members. And how they do that is through some of the measures that I mentioned, which is HEDIS and QARR. So managed care companies, in order to survive, really have to start working with providers. It's really the only way that they can move forward in this new landscape. Okay, so a lot about how we think lies a managed care company. Well, why does it matter? And again, my guess is, based on the folks that are on the phone, that it depends on where you sit about how involved you are with a managed care company. And I actually think that some of the offshoots, if I'm not mistaken, of managed care companies is some of them are providing health home care management services. Some of them, not all of them, which is interesting. So one thing that managed care companies have is data, okay? And data is a powerful tool in providing health home care management. The powerful tool is because I think, and I don't know if anyone knows because I don't know, health home first started, there was lists given, and I believe those lists still continue about health home eligibility. And what I heard is that of those lists, that the health home engagement rate was somewhere around, and correct me if I'm wrong, at the high end 25%, at the low end maybe 20%. So for every 10 individuals that the state gave you a list, you're able to connect with 2 or maybe 3 individuals out of those 10. So we'll have to check on that. But my point is that they're difficult folks to find, a lot of the folks that are eligible for a health home, and certainly the higher risk patients. So that can be helpful because they have data. What is data? They have data on who the individual's primary care provider is or specialist, because the folks who are higher risk don't get primary care. Maybe they see a cardiologist in order to get most of their needs met, kidney specialist. So provide information about who that individual goes to the most. Determines where they utilize services. And the reason why that's important, really begin to figure out how we can get to these individuals. One way that we can know how to get to these individuals is, are they going to the ED a lot? Utilizing inpatient services, okay? The MCO has that information. And that's really important. And the other, one thing that I would encourage at least the lead health homes to do, and I know this is happening throughout the state, but if it isn't happening in your area, is the lead health homes, the state is asking the MCOs, the managed care companies, to really partner with the lead health home around sharing this data, sharing information about when somebody is inpatient, sharing when they're using the ED, and trying to get to the individual as fast as they can when they're utilizing services in regards to outreach. The other thing is, the other way that an MCO can be helpful is if someone's having trouble getting access to a primary care provider, the MCO is held to a standard. For an individual, they have standards with their primary care physicians to get individuals into services quickly. So if someone's having trouble accessing services or they need help locating a provider, you need to have that work with the individual to call provider services or member services of their particular managed care company and say, look, I can't get anybody. Next appointment they have for me is 4 months. This is where I think a little advocacy on the part of the health home CM to empower the client or to work with the individual that you're working with to, sorry about that, I don't like to use client, to work with the individual to get them into the care that they need. Someone's going to the ED 7 times, good to link up with the emergency room department manager to say, hey, when this person comes, they've been in your emergency room 10 times in the past 3 months, can you give me a call? I think even having those high-level conversations would be good to have. And MCOs can help facilitate some of those discussions. These are things that we talked about. Again, the lead health home is really encouraged to interact with the MCO. One thing to consider is that some of the high-risk patients that you guys are interacting with do have case manager contact. And then, they have a case management program. Chances are, certainly if they're going in and out of the hospital, they might have a case manager already involved. Working with them to get information on how the individual receives care would be helpful. And I always think, again, this might be a lead health home activity, is trying to figure out who to contact in the MCO if you need help. Again, I can't emphasize enough the goals line with the MCO. Certainly, I'm not naive. Cost is important with MCO. Describing cost, the quality of care that the individual receives. You have a direct impact on that. If you're actively working with an individual to take a role in their health care, you have the ability to provide support not only to the MCOs but a lot of providers. So this is what MCOs care about now. 3 items: quality of life, prevention, people taking an active role in their health care. I think what we'll do is we'll look at a couple of interventions you can utilize for a primary care provider, some tools that I can give you, and then as we wrap that up, we'll just kind of summarize where things are at and take any questions from the group. Okay, hey, we're in the home stretch. What I want is helping folks, and again, this is a good exercise for me as well because, questions, what are some things that we can help people to ask when they go see a provider? Symbols of a personal health record, and how do we, and maybe I should change the slide to collaborative outcomes. Working with providers, what best way to meet some of their objectives. A couple of tools for you guys to look at as well. So one of the ways that we can be helpful, certainly with more complex individuals or high-risk individuals or individuals that have more chronic conditions, is how to help them plan for a medical appointment, okay? Here's something about. And with someone with a medical appointment, there's a lot of things on this slide and it's a little busy, but I think just even put these 4 bullet points onto paper just have folks create some ideas about their health history, some of family history, medications, and maybe asking someone to go to your appointment, okay? And I think it's important with folks that are more complex to get some of these things down on paper. What I gather, the expectations of a health home provider are pretty high during the assessment phase. You might be able to give them your assessment of what you're seeing in the health history that they gave you. Some of the data sets and the tools that you're utilizing, and sharing those with the individual. Why not? It's your assessment, it's their assessment. I'm all about transparency, and they're seeing what you're utilizing to help them. Because A, it would be good to get their feedback in regards to accuracy, but B, it could be a tool for them as they interact with medical providers. What I want to call out here is bringing medications to appointment. One of the things that one of the highest predictors of readmission is related to med interaction and med compliance. And so I don't know if that's the highest predictor, but that's certainly in the top 5. Medications is a big deal. A lot of times, individual goes into the hospital, they're started on medications, they stop medications, they don't continue medications, and folks are really confused. And one of the best interventions or ways that I think we can be helpful is if we're able to have a home visit with the individual. Is where it's that individual. A lot of people have smartphones, and even you don't even need a smartphone. Any type of phone where you can take a picture. Is I would line all the medicines up on the kitchen table if they have one, or the counter, or the table, couch for that matter, and have them take a picture. Take a picture of all those medications, and you would be surprised how the provider, and it's really, I can't blame the providers in this instance, especially when someone is facing with a lot of different providers. Things happen so quickly that really doesn't catch up to the provider sometimes in regards to the medications. So what I do is take a snapshot of those medications, or have the individual take the snapshot of those medications and bring them to the appointment. And working with the provider about all those to start, stop, and continue, right? What do you need to start taking? What do you stop taking? Because I don't know about you, individuals' experience being in a hospital. Really what happens is a nurse will come, review the discharge plan and all the medications, especially if you have someone on 15 medications. What's the individual in the hospital bed going to say? They're reviewing the medications. The nurse is going to say, do you understand the medications you're taking? The individual is going to say, yes. That'd be the end of the conversation. So I cannot emphasize enough how we can really be impactful in regards to the medication question and helping not only the individual but the providers. The thing to think about, especially again with more complex individuals, and I know it's hard for folks, especially with caseloads, but there might be times where it might be helpful to go to the appointment or ask a family member who is knowledgeable about what's going on with an individual to go with that individual. Because you'd be surprised about how much is missed in that 10 or 15 minute visit. And the only example that I can have related personally is when I went with my father, who's 72. I went to him with on a visit because I was concerned about him. And the doctor and him had a conversation for about 15 or 20 minutes. The visit was ending, and my father neglected to tell them that he had 4 falls during the past 3 days. So if I wasn't there, that conversation would not have happened. Well, I don't know if it's having someone go to the appointment, jotting down, working with the individual, because again, especially my example is he was on a new medication, my dad that is, he was falling, the provider didn't even know that was happening until I said something. So you have to start to prepare individuals for these appointments because time is precious with their physician. Maybe writing some of this down would be helpful. Okay? Some things to think about. Okay. In regards to the provider interaction, again, we reviewed a lot of these. Again, do folks even know what their diagnosis is? Why am I going to this test? I don't understand why. What's in it for me? And we spent quite a bit on some medications that are role of medications and how that's really important to the provider interface. Okay, and so I'm going to step out of the presentation for a bit. Hopefully you can see it. And there definitely is a lot out there about how to plan for a doctor's visits. I put in a couple links, and again, we just don't want to overwhelm people, but we want to make sure at least we have their top concerns. I put links in there for all of you guys, and I think they'll go out with the presentation. Again, be a little bit overkill, but I think if you know the individual that you're working with, what are some things that you can glean from that would be helpful? The form is extensive, but it might be good maybe to give them some information on this form to the PCP, especially if it's a new provider. Okay, let's see what else I have here. Okay. Okay, so here real quick. And we'll sort of end on this note here, is creating a personal health record. And I think it's, again, why this is so important, having a PHR, is it really begins to help you track how your health is going. And I can tell you that certainly if you go to your insurance provider, they will have some slot on the website about a personal health record. And what I would encourage folks to do is maybe take a look at the tools that are out there on the particular websites and maybe get a one-pager yourself, and then see if it'll be helpful with one of the clients. Because we're not accurate reporters as human beings. We're not good at this stuff, especially when we're sharing information back and forth with our doctor. We need to write stuff down. We need to have questions ready and know what information that you want to share. Benefits, again, there's the individual. So again, they're tracking their progress. And really what it does is it forces the issue about what's the priority for the individual. This is another way to get at it. Because you're sitting with an individual that was just admitted medically or even in a behavioral health setting, they go out and they say they really have no concerns, they feel pretty good. That'd be an interesting discussion to have about, okay, if that's the case, do you have any concerns? I mean, so you just were hospitalized, you have a lot of medications, so you're really starting to begin to have the conversation with that individual. An example of a personal. I like this one because it's a one-pager. I gave you guys the link. I'm a big believer in trying to keep it short and sweet. I gave you a whole bunch of links to get to some personal health records. Let me see if I can pull one up for you. Okay. All right. Okay. So, I mean, just in summary, I mean, I think the key thing is how can we collaborate with providers? And I did want to put I did add a couple of slides in here about some tips or some things to think about in regards to working with primary care offices, specialists, and also behavioral health providers. And I know a lot of you folks might be in these positions, but for folks that are more outside of these systems, internally as well, as some things to think about. I mean, we talk about about individuals' readiness to change. I'm a firm believer that there should be a lot of research on provider readiness to change. I don't think we ever think about that. We always think about the individual. I think we need to think about as each provider has a unique way of interacting with individuals. How do they communicate? What are their expectations of what we can do for them? What's the plan about how we can work together? Is this provider culturally competent? I think these are really important questions to ask because, you know, we do spend a lot of time looking at, again, individuals, but you have to look at providers. You know, I'm sure that you guys have experienced this, is that you can have one provider who's really open, knows what a health home care manager is, utilizes you as a service. You might have a provider who's by themselves or maybe have 2 or 3 docs, won't even let you in the door, don't understand your role, are confused about why you're calling them. Do you have a release? So I think that understanding where the provider is at is something always to think about. Okay? And having conversations with individual providers, right? It's just like individuals that you're trying to engage. Why should I care that you're a health home care manager coming to help this patient? And I think you have to really share with the providers what your value add. And a lot of value. You have real-time data. You know where this individual, most times, especially if it's a high-intensity individual that you're working with. And what I mean by real-time data is you know if this individual is working. You know if this individual is sleeping all the time. You know if this individual potentially is abusing substances. Data is invaluable to providers. The other way it could be valuable is helping to address the social determinants of health. If a provider knew that you can help an individual, a struggling diabetic, get medications, you're going to be invaluable to that provider. So you can access services. If an individual has a lot of transportation needs or needs help getting into employment services or needs help getting things for their children for school. Again, if you bring this to some of the providers in the more urban settings and rural settings, it doesn't matter any setting, that's the value proposition, and I think you start to build upon that and the relationships that you have. Some things to consider. Okay, the provider have a case manager on the team. A lot of them do now, especially when they're called upon to look at quality. Resource for sharing information with the provider. Some providers want you to call the nurse and leave a message, maybe call the case manager. They don't want to have any phone calls, just drop off your questions so you understand how they want information shared. And because most likely your interface, I think, would not be with the PCP. Other providers certainly, that maybe not even have an office staff because that happens. You know, how do they want the information shared? And attend a visit if possible. And this is more for the extreme cases because I know caseloads are high. There's a lot of demands on health home care management time. But if someone's really struggling or a higher risk, it might be a good way to go. Things to think about communicating with the provider. Okay, you know, again, we talked about medications. Are you, meaning the health care manager, seeing any changes in behavior? Do you do any testing at your site? Do you do a PHQ-9 and SBRT, which looks at, you know, substance abuse screenings? If you do these things, again, and there's positive screens, that would be important for the provider to know. And in regards to DSRIP, one of the biggest initiatives is integrating primary care and behavioral health. So some of the stuff is already going on, and hopefully information is being shared. And also follow-up appointments. You can really support the provider to know whether or not they made it to a particular specialist. And the key thing here is keep calm and empower people. So a lot of things going on, a lot of things being thrown at us, and how can we sort of chip and try to help folks get to where they need to go. And I gave you some tools and resources related to self-management and providing information. I can't emphasize this enough. Collaboration is the priority. Putting an emphasis on value, and all of your goals in health management align with all the other initiatives. People need to know that health home care management is available, meaning providers. I would encourage you to start linking with, certainly the best place to start might be large volume providers, and now health home can be valuable to them, and it's an ongoing conversation. That's all I have. I did put some references in there, and like I said, the tools and resources will come out with the slide deck. I think what we're going to do is see if there's any questions from the group.
There was a question. I see the list of services, and I think these are the PPS services, but who is providing them, and what are they actually going to do for clients? Jim, if you want to clarify that you're talking about HCBS services.
Yeah, so it's a list of services. There's what I would encourage you to do is look in your community for these particular services, because a lot of different organizations are involved with this. I can think of that for instance, and again, it depends on where you sit, but I'd almost go to the OPWDD site and start to look at this, because you know, I know in the old days it used to be vested, but there are employment agencies, peer coaches. My guess is those individuals would continue to provide those services out there. And if you even Google job coach and put in the county, you start to see a list of those services. In